Okay, thank you. So this is obviously an important topic, but also a very broad one. And, I'm not really a subject matter expert per se on CAR T, and I'll lean on my colleagues on the call if I can. But, some thoughts that came to mind looking at this topic include, really early aspects of graft design and engineering, the target antigen, how the graft is prepared, TKI is used in graft engineering, new approaches that are coming along in terms of trying to improve T cell fitness, through to timing of dosing. What stage of treatment? Is it solely at relapse, or as we move immunotherapy increasingly into frontline therapy or towards the front line, then what time is best for CAR T, and then what is post CAR T therapy now looking like? There are some studies looking at prognostic effective factors such as B cell aplasia and loss of that. When is transplantation indicated or not indicated? So, just some initial thoughts. Perhaps I'll stop there and open it up for broader discussion from those on the group that are directly using CAR T in particular.
Here my observation on this. Number one, we all know that the outcome with CAR T is best if you have less tumor up front. So therefore, what is the best sequence before give CAR T? Do we give CAR T minimal disease? And if we do so, are we concerned about expansion thereafter? At our institution, it has been the norm to give CAR Ts in somebody with no disease or minimal disease. Then the second question is that you brought it up is post-CAR T, do we go for allotransplant or CAR T as a finite therapy? Of course, the answer is easy if you have somebody who already failed transplantation and you give CAR T and you have somebody MRD negativity. But to be more problematic, if somebody who did not receive transplant upfront, you give CAR T, you go for transplant subsequently. The only CAR T available today for adult in USA above 25 is Brexucel, and it's 41BB cosmetic domain. Actually, it's CD28 cosmetic domain. Therefore, the cells are not persistent, and there's no B cell aplasia. We do not know if MRD negativity by NGS alone is enough, because from the ZUMA-3 trial, there is no tail, there's no plateau. Patients are still relapsing and dying. No, in a Kymriah Tyza-cell, the 3 years update showed that those who had B-cell aplasia at 12 months and beyond maintain the remission, and they become MRD negative by NGS 10 to minus 6. They do not seem to relapse. Now we have a new CAR T coming, obe-cel. Maybe if we can get into MRD negativity by NGS, post-CAR T transplant may not be needed. I think we need more data and more follow-up, but hopefully one day we can show that CAR T done earlier than later, in no disease or MRD, and post-CAR T, if we have MRD negativity, we do not need subsequent transplant.
So, okay, thanks, Ellie. Great comment. So again, just to clarify, so if you achieve MRD negativity post-CAR T, you are not transplanting, or does it depend on the timing and prior treatment?
I think if somebody, if somebody had already failed transplant and they become MRD negative post-transplant, post-CAR T at 3 months, we're not transplanting them. We monitor them by NGS every 3 months at 10 to minus 6 at least. And if somebody had not received transplant before and they're young and they have transplant option, you can entertain this question. It's debatable in our center.
What factors do you use to determine?
But the key is to get MRD negative by NGS.
Yeah. Are you swayed, for example, by the subtype of BALL or other factors in making that decision about whether to transplant or not?
Not at this stage.
No. Other thoughts?
I think that what Elias already mentioned are very important factors to be considered, and the strategy of managing patient CAR T cells, and the issue of getting MRD negativity assessed by NGS is certainly a relevant factor, as well as the information about the previous allograft that the patient may have received. Let me add also a couple of further issues that should be in principle considered in terms of optimization of outcomes in children and AYA patients receiving CAR T-cell. The phase 1 is the possibility of using an allogeneic product, namely CAR T-cell manufactured directly from the allogeneic stem cell donors, in particular for those patients relapsing very early after the allograft. There has been a very nice paper published by Peter Bader and the German pediatrician clearly documenting disappointing or in any case worse outcome in comparison to patients either never transplanted or relapsing more than 6 months after the allograft. And the second issue that I'd like to offer to your consideration is also the possibility of manufacturing the CAR T cells starting from a fresh material and infusing fresh CAR T cell. And this is something that is going to be developed, at least in Europe, inside the Interel consortium, using the approach that has been developed by Milteni, also considering that in this way, there will be the possibility to run a trial based on the manufacturing of the CAR T cells in the academic GMP facility, and this could render the approach even more affordable from an economical point of view for the perspective of a national health system.
Thanks, Franco. Great comments.
Another issue could be the administration of fractionated CAR T cells in order to avoid the toxicity, so and sparing the effectivity. So I think reducing toxicities as an important milestone to achieve with CAR T in order to have a good result. So really fractionating the CAR T has clearly diminished the toxicity at least in one academic trial from Spain, and there are other commercial trials that are doing this approach also.
This is the trial, the FELIX trial that was reported by Claire Roddy last year, last ASCO. An update will be presented at ASH, where they fractionate the dose. They give, if you have blast below 20% up at the time of the conditioning, you get a higher load of cells. So they give 410 million, and they give 100 million if you have low tumor burden, and 310 thereafter. In contrast, if you have high tumor burden, more than 3% of blast, you get 10 million on day 1, on day 10, you get the rest. But on top of that, there is what you call the fast off, the low affinity bindings that may play a role. And in this trial, they have a low CRS rate, grade 3 is 2%, which is, and the less ICANS, of course, 7% as well.
Charles, let me share just a more general thought about this question. It's intriguing. We are moving to bring immunotherapy, especially a monoclonal antibody, up front to any type of frontline ALL in adult and even in pediatric. And that, of course, has been promoted by a company and clinical studies supported by that. Unfortunately, and I follow what Franco has already alluded to, this is not going to be the same landscape for CAR T. And this is a pity, because still we don't know, follow what Ribera said before, what is the best, even in the frontline, time frame where to introduce the CAR T. And just because it's unlikely that we'll have comparative study between monoclonal antibody and CAR T, this is making the landscape in our field very challenging for the future.
Yeah, great points. And I wonder if part of this as well is also related to the complexity of issues related to access and engineering, that it's usually at least not an off-the-shelf product, but it requires, making of a patient-specific product and a long turnaround time. Do you think that's a factor, and can that be improved?
Well, I am pretty sure, and Franco has already mentioned that an easier system for production is definitely one way to move on, and possibly even the use of allogenic or even fresh material instead of. So I'm raising this point because what is my opinion mandatory that in parallel to the use of commercial product and accordingly clinical studies supported by company, we do need to have academic studies showing that we can introduce this type of therapy even earlier, and not just because, just as it is now, only for relapse refractory, which, as already mentioned, then raised a lot of additional points in terms of what are you doing after that, and accordingly reducing its impact.
Yeah. Any other comments?
Just following what Andrea just said, let me comment that probably the interest for the companies for running trials in earlier disease phases is limited. For example, I mentioned before the Enteral initiative with the Milteni approach through the decentralized manufacturing. But before reaching this agreement, we approach the only company that has a product commercially available for the pediatric population, and they clearly stated that they weren't interested to further invest in company-driven trials, and thus this is a further argument for trying to support academic studies able to fill the gap and to test the role of the CAR T cells in earlier disease phases of pediatric patients and adolescents and young adults with B-cell ALL, and also that the study that was designed to test the efficacy of the CAR T cell in patients with a high level of MRD at the end of consolidation treatment is still facing a lot of issues in terms of patient recruitment.
That's an important point. And of course, another challenge, at least in the US, is for new CAR T opening trials in the pediatric context and not just in the adult context, which is an important issue. What about the second bullet point about managing relapse after CAR T? Thoughts about approaches there? I mean, I guess some thoughts that might come to mind are the nature of relapse. Is it in the context of CD19 CAR T? Is it CD19 negative relapse? Has there been a loss of B-cell aplasia? Those sorts of factors. Are people got specific real-world experience or thoughts about the appropriate approach?
And the other issue could be that by trying to develop further strategies for the simultaneous dual targeting of, for example, CD19 and CD22. And this could be another type of approach that could improve the results, preventing the occurrence of leukemia recurrence with the emergence of CD19 negative subclones.
So are you pursuing that, Franco, in Italy? What are your thoughts about your targeting?
We are working on this, but we still do not have a CAR construct that can be used in the clinical setting. Although, again, one company, and it is again Milteni, has the plan to develop this study using their CAR construct with the simultaneous targeting of CD19 and CD22, but that's still it's a sort of project in the pipeline without any concrete application at the moment.
Thanks. Others' thoughts? Ellie, can I touch on you again? Do you have thoughts about how you approach disease recurrence after failure of CAR T?
You know, this is an area of unmet need because most of them, well, if they fail CD19, what we're doing at our institution, doing CD22 CAR T or CD22 antibodies, often they have CD22 expression. I know at UPenn they're doing CD19 and 22 CAR Ts. At my institution was CD22 CAR for these patients. But nothing magical. And then we're exploring navitoclax in this setting as well, BCXL and BCL2 as we did together the work in a phase 1. And yesterday I was reviewing the data. We have treated post-CAR T at 15 patients, and seven of them are responding. Now, of course, responses are short-lived, but at least to get you to go for an allo transplantation subsequently.
Any other comments?
Well, Charles, actually, as already said by Elias, when you are deciding to use the CAR T and in relapsing patient, at least in the pediatric setting, and you are losing the B-cell aplasia, or at least you have even worse scenario, the increase of the MRD, but even at the earliest stage, when you have the B-cell aplasia, at least within the 6 months after infusion, the only way to proceed in terms of treatment is, as been already said, to proceed to allo transplant if you really want to, if the general condition really provide the setting for moving towards this, let's say, second or third round of treatment. I don't see any other option that you have in the pocket.
Yeah.
Yeah, but the problem is to make a subsequent transplantation with a high bulk of the disease. So we have to debulk the disease in order to have an opportunity for stem cell transplantation after CAR T relapse. I think that proceed directly to allogeneic transplantation is not a good issue because especially in cases of frank relapse. Another issue is MRD positive relapse. So it's another issue, but if there is a frank relapse, I think that we have to do something before transplantation.
No, absolutely. Jesus, I'm just referring to the, let's say, the attitude of, let's say, of the pediatric setting is, of course, you monitor the B-cell aplasia firstly, and then is an indication not of relapse, but definitely an indirect event, a proxy event that in most of the cases, when it's happened very early, the relapse will occur. So you're not waiting the relapse time. And then, of course, you have the MRD switching. And then, of course, even in that case, as you said, it's definitely problematic to proceed directly to transplantation. And even worse, when you have a frank, bulky relapse after CAR T. So absolutely agree on that. So there are 3 different scenarios that we are to consider in terms of clinical decision.